learning something about high tibial osteotomy and medial compartment arthritis, which we all know is an effective joint sparing companion in medial compartment wear. We all know that cartilage degeneration of a particular compartment of knee joint is usually the result of overloading of medial compartment, which is associated with so-called malalignment or varus deformities of the lower extremity. High tibial osteotomy as a realignment osteotomy procedure is applied to basically transfer the medially deviated mechanical axis to the lateral compartment in order to unload the medial compartment and delay the process of osteoarthritis. The aim of high tibial osteotomy is not only to eliminate or reduce pain, but by doing so, we translate loads to the contralateral compartment, as a result of which it aids in cartilage regenerative process. Now, looking to the tibial osteotomy, before that we'll be discussing something about the normal mechanical axis of body, how our weight is going to get transmitted from hip to ankle, and what are the major axes that plays definite role in transmitting the weight. We all know that mechanical axis is an important aspect of weight bearing load axis. It passes from center of femoral head to the center of knee and to the center of ankle joint. Whenever this line passes through the medial aspect of joint, this is known as varus malalignment, and when it passes through the lateral aspect of joint, it is known as valgus malalignment. So a mechanical axis of lower extremity is a very important structure, a very important landmark that decides our future outcome with respect to load sharing and load bearing of knee. There are various angles which, when deviated from their normal axis, results in abnormal load sharing or load bearing in particular compartment, and that causes overloading of the particular compartment joint, and it results in asymmetrical mechanical wear of that joint. We all know that the mechanical axis and anatomical axis have a variation of about 6 degrees because the line that passes through the shaft of the bones are forming the anatomical axis, and that passing through the center of joints from femoral head to ankle forms the mechanical axis. So in order to calculate the deformities, we usually concentrate on this mechanical axis, and therefore we measure the respective angles, the most important being distal femoral angle or the proximal tibial angle. When we talk about the joint aspect, we know that the congruent surfaces are not symmetrical on either side, and there comes the role of femoral and tibial joint angles. We know that femoral joint angle is usually 2 to 3 degrees of valgus to mechanical axis, and tibial joint line axis is 2 to 3 degree varus to mechanical axis. So these are the normal joint line angles at the respect of tibia and femoral surfaces. So how to calculate a varus or valgus deformity? To know that, as we have discussed earlier, that mechanical axis is very important, and when we draw a straight line from the femoral head to the center of joint, and when we extend it distally, then an angle which is formed between the mechanical axis and tibial shaft axis, that helps in deciding what kind of deformity we are suffering from. So this mechanical axis is very important to label whether it's a varus or a valgus deformity. The deformities, whether varus or valgus, can be at multiple levels. It can be over the part of femoral side of joint, over the tibial surface of the joint, it can be within the joint itself, or it can be an extra articular angulation due to any significant trauma or osteotomy done earlier. So when we are thorough with this, that it's either a varus or a valgus deformity, then we have to decide at what level this deformity is. As we have discussed earlier, it can be over the femoral aspect, over the tibial aspect, inside the joint, or extra articular. So here comes the role of the femoral and tibial joint axis. So we all know that femoral axis is 2 to 3 degree valgus and tibial surface is 2 to 3 varus of the normal joint surface. So in order to calculate where the deformity lies, we can compare these joint angle with the comparative sides or with the normal side, and we can therefore calculate amount of varus and valgus occurring at particular level. So, so this was a basic concept of uh, medial compartment of a deformity at the level of knee, femur or tibia, and how do we calculate the angles. Now we'll be talking something about specifically medial compartment osteoarthritis with a varus malalignment. We all are aware that this can be treated both with the help of medicines conservatively or as surgically. Now depending on the age of the patient, the results vary and the kind of procedure to be administered varies. So the main two procedures when a patient is not responding to a conservative line of management, then with a significant varus alignment in a middle age to or an early arthritic cases, we usually prefer to go for alignment axis correction. So this can be done either with the help of a high tibial osteotomy, that can be a medial open wedge or a lateral closing wedge, but we will be talking something about medial open wedge. The other surgical thing which can be done for such varus malalignment is unicondylar knee replacement, but it has got its separate drawbacks. So we'll be discussing each of them in a nutshell down the line. There are numerous presentations, numerous publications that are present which shows the efficacy of both the procedures done in a particular set of individuals, and one such paper says that in a younger age with a varus deformity, those were associated with dissatisfaction following UKA, and HTO has served to be a better procedure. So in a younger age group where we don't want to sacrifice the joint or we want to spare the joint, and with a varus deformity, a high tibial osteotomy will be serving a better prospect. There's another presentation or publication by Zhu Wang, published in 2017, which tells a meta-analysis of role of unicompartmental arthroplasty and high tibial osteotomy, and it has been found that HTO group achieved superior range of motion as compared to UKA group when compared to the age, body mass index, grade of osteoarthritis and patient's activity. There is another study which says that high tibial osteotomies in patients with stage 2 and 3 knee osteoarthritis have different kind of results, and H2 is more effective in early osteoarthritis. So what are the indications for an osteoarthritis? It can be a varus deformity with medial compartment osteoarthritis. It can be an adult OCD, osteonecrosis of a particular compartment associated with PLC instability, and as a protective procedure for a chondral resurfacing. Which is an appropriate patient for such kind of osteotomies? A younger individual with age of less than 60 years. He is an active, male or female, motivated for rehabilitation with an ideal body mass index of less than 30. The appropriate joint, we all know unicompartmental pathologies are basically treated with HTOs. They should have definite correlation with scanograms. It should be a non-inflammatory arthritis. The flexed flexion deformity should be less than 15 degrees with a good range of motion of more than 90 degrees, and the maximum limit of varus should not be less than 15 degrees. Whenever we do go for a procedure, there are certain kind of contraindications. So some of the contraindications are lateral compartment wear, lateral meniscectomies, previous history of injury to lateral compartment, significant symptomatic patellofemoral arthritis, inconsistent pain that is not justified with the help of the radiology, obesities, inflammatory arthropathies, deformities more than 15 degrees, and heavy numbers. So for any surgery, we know our pre-operative planning is very important. So we have talked about ideal patient. We know how to calculate the deformities either at the level of femur, tibia or both. We want to measure the deformities with the help of mechanical and anatomical axis, what amount of correction is required, what kind of implant to be used, and whether a bone graft should be required or not. So first, looking for the deformity, we can measure a deformity with what is known as a scanogram. So it is a weight bearing pictorial radiograph from hip to ankle that shows the variation and the deviation of normal axes. We can go for MRI to rule out other compartmental disease or other associated ligament malfunctions. We all know that mechanical axis plays an important role in pre-operative preparation. Whenever there is a 2-degree varus, the weight distribution occurs in such a way that 75% of body weight transfers to the medial aspect. In case of 4 degrees of valgus, there's almost 50-50 weight bearing or weight sharing between both the condyles, and with a 6-degree valgus, more of the lateral compartment view occurs. So correcting angle can be measured with the help of angle of deformity, and how much to correct. So we need a minimum of an average of 5 degrees of valgus, so we add that 4 to 6 degrees of valgus to the amount of mechanical deviation through axis VFC as an angle of deformity. So the most important aspect while deciding what should be an ideal case of high tibial osteotomy, we look about the Fujisawa point. Fujisawa point is almost 62% lateral from the medial aspect of medial tibial condyle over the tibial plateau, where we have to transfer the mechanical axis, so that the medial compartment wear is drastically unloaded from the medial compartment. So we know that how much correction we need. We have calculated the angle. The general rule of thought is that we need a medial opening in millimeters, and for first 10 millimeters it corrects about 10 degrees of correction. Means for each millimeter of opening we correct about 1 degree of varus deformity. So this acts only in first 10 degrees of correction. Following that, the correction in degrees is less as compared to the millimeter required. So a CM can be used, or a navigation system can be used to align a proper axis to get a favorable result. So here's a scanogram, and what we want to do here is we have to shift this mechanical axis that is transferring from the medial compartment to about 62.5% of the tibial plateau from medial to lateral. And if we see over this diagram, when we calculate a weight bearing axis, normally the weight bearing axis in this particular is passing through the medial compartment. So how much angle is required to be corrected? So that all depends. When you pass this mechanical axis to the center of joint, then the angle which is calculated between line A and B is the maximum angle of correction we want to achieve. So what are the 5 parameters that helps in medial opening wedge osteotomies? So important is the cutting point, where we will be starting, amount of lateral hinge that to be remanded, the direction of saw, the depth of saw, as well as the correction angle. So usually this distance from the tibial plateau towards the most concave point is almost in the region of 3.5 to 4 centimeters from the surface, and it acts as the starting point for our osteotomies. The kind of fixation device which can be used for securing the osteotomies can be a spacer device like a produce plate. It can be a rigid Tomofix kind of appliance, or recently discovered or recently invented curved plates like this kind of plates, where we can go for associated ligamental surgeries or slope correcting procedures if required. Whether we require a bone graft or not, it all depends on the kind of osteotomy. There are multiple school of thoughts which decides whether it's bone graft is required, and we have a multiple, but we definitely know that opening wedge osteotomy requires a bone graft for protection. It acts as a structural support, it enhances the biological healing, it acts as a scaffold for growth factors, and various type of grafts can be used, whether autograft, allograft, or a bone graft substitute. One such paper published in 2015 says that whether bone grafting is necessary in opening wedge high tibial osteotomy or not. So it says that it is difficult to commit whether the currently available evidence shows sufficient strongly support to support a bone graft or not. But another paper that was published in 2019 shows that graft material, it provides greater static strength to medial opening wedge high tibial osteotomy than when no graft is given. So in a nutshell, we can say that when the opening is more than 10 millimeters or there is a correction of more than 10 degrees, we definitely protect our osteotomies with the help of graft. All surgical procedures do have complication, and range of complications is about 12.5%. So that is directly proportional to the size of correction we have achieved. The major complications can be a fracture, it can be a non-union of osteotomy site, over and under correction. If there is definitely effect on patellofemoral joint forces because of the advancement or relatively lower level of tibial tuberosities. Any surgical process can have infection, thromboembolic events, and a neurovascular injury. So we might be well prepared for any of this complication, and we should have all the backups required to deal with them. This is some of the clinical examination. Here we can see the periosteum is elevated from both the anterior and the posterior aspect. The size of the incision is almost in the range of 6 to 7 centimeters. With the use of guide wires, we just insert and decide the plane. Everything to be verified under fluoroscopy, that how much has to be done, how much cast has to be done, how much deep we have to go. Usually it should be about 1.5 centimeter to the plateau surface of the tibial condyle, lateral tibial condyle, and a minimum of 0.5 millimeter of wedge should be present. If we drill a longitudinal wire, then it helps in definitely protecting the lateral hinge in breaking or causing fracture. We subsequently check under image intensifier with the help of long rod about the anatomical axis that should pass, or a mechanical axis that should pass from the center of femoral head to the center of knee, almost just touching the lateral compartment, that is 62.5 or Fujikawa's point, and towards the center of the ankle joint. Here we can see we have gradually opened with the help of the wedges. Here the osteotomy, verified under Shyam the mechanical axis, we can see, and this is finally protected with the help of a curved plate, as we can see here. So it's a wonderful device that helps in holding the osteotomy site, and I usually prefer to put a graft or a bone wedge substitute in those conditions where my osteotomy is opening more than 10 millimeters. So in nutshell, STO is regaining popularity, specifically in younger and active individuals which are having high expectations for physical activities with increased life expectancies, and in order to preserve the native joint surfaces. The optimization of realignment osteotomies occurred as a result of modified surgical instruments and techniques, and they provide us more reliable outcomes, and a proper patient selection with meticulous technique can create wonders in the field of joint preserving orthopedics. Thank you.